Hello, everyone. My name is Gurjot Basra, and I'm the Manager of Patient Programs, Research, and Advocacy here at Lymphoma Canada. I'm very pleased to welcome you all to this breakout session on cutaneous T-cell lymphoma, also known as CTCL. So just before we start, I do want to go through a few housekeeping items. So this Zoom software does not allow you to access chat features or turn on your microphone. So if you have a question, this session will be followed up with a live Q&A session, so please keep your questions in mind and be sure to attend the CTCL Q&A afterwards. So to introduce our speaker today, we have joining us Dr. Jory Harden, who is a clinical associate professor in the Division of Dermatology at the University of Calgary. She is the co-director of the Calgary Cutaneous Lymphoma Program, where she oversees the care of over 300 patients living with cutaneous lymphoma, servicing all of southern Alberta, interior BC, and parts of Saskatchewan. Outside of her clinical role, she is the Dermatology Residency Program Director responsible for the training of future dermatologists. So thank you, Dr. Harden, for joining us today, and you can get started as soon as you're ready.
Great. Thank you so much for having me, Gurjot. It's a really, this is a topic that's near and dear to my heart. And it's, again, a pleasure for me to be here today. Um, so let's dive in. There we go. I'd like to start with a land acknowledgement. When I think about land acknowledgements, I use the book called Unreconciled by Jesse Wente as a guide. Jesse Wente is an Indigenous author, a broadcaster, an arts leader, and he describes land acknowledgements as a recognition that I am visiting someone else's land as a white settler. He says that Indigenous people contextualize themselves so everyone can better understand where we're coming from, whether that's your name, your family, the land you reside on. For non-Indigenous people, a land acknowledgement should serve as an effective reminder of the history of the space that we occupy, our relation to it, and the obligations that come with sharing the land. Today, I would like to recognize that I live, work, love, and play on Treaty 7 territory, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani, Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, which includes the Chiniki, Bearspaw, and Good Stoney First Nations. Um, in Calgary, where I reside, is also home to Districts 5 and 6 of the Métis Nation of Alberta. This is a picture taken maybe 2 weeks ago on a hike that I did with my pup in beautiful British Columbia. So many of you who will be listening are familiar with my friends and colleagues, but I thought I would introduce ourselves. The picture on the bottom left is me and Dr. Leslie Street. Dr. Street is the co-director of the lymphoma program with me. She's the hematologist that works with me. She joins me, or I join her 2 half days a month for our patients that need both of us present. The man in between us there is Dr. Gilles Lauzon. He is the real founder of cutaneous lymphoma in Calgary, and was a mentor and is still a friend to me. And then in the top right, that's Dr. Street again, and this is Dr. Robert Niedecke. He's the dermatologist in Edmonton who runs their cutaneous lymphoma program, along with Dr. Meenakshi Taparia, who's the hematology partner there. So I feel very privileged and grateful to have such a wonderful support system and a very robust cutaneous lymphoma program in Alberta. Some of the numbers of just patients that we're seeing in Calgary, this is as of September 2025. We now have over 450 patients with diagnoses of cutaneous lymphoma. 100 of those, I would say, are followed very closely by Dr. Street and me jointly, meaning they have more aggressive disease. Mycosis fungoides, which we'll talk about, is the most common diagnosis. And we're also going to talk about this entity called CD4 positive small medium T cell lymphoproliferative disorder that's really emerging as a very common referral that probably doesn't need to be followed in a lymphoma program. And then lastly, we'll address Sézary syndrome. Those are our top three kind of referral diagnoses that we see. And as I mentioned, we're very lucky to work closely with radiation oncology and the apheresis team in Calgary. We also do bi-monthly provincial cutaneous lymphoma rounds, and that's with a hematopathologist. So the patients who review the biopsies that we take, we can share our challenging cases with the Edmonton group. So primary cutaneous T-cell lymphomas are actually a big umbrella of many different diagnoses, of which, as I mentioned, mycosis fungoides is the most common type. In this presentation, all of the pictures are from patients of mine, and we'll go through the morphology as we dive in. Diagnosing mycosis fungoides is exceptionally challenging. It has a presentation that can look like eczema, it can look like psoriasis, it can look like tinea corporis, which you might know as ringworm. And there's no single diagnostic test. It's not diagnosed with a blood test or even a skin biopsy. Often it requires a combination of multiple biopsies over time, and the clinical presentation as well as other investigations if they're needed. Unfortunately, many patients have a long delay from their initial presentation, previously being treated as having eczema or psoriasis or another dermatologic condition for sometimes years prior to receiving their diagnosis. This is not a matter of ineptitude or incompetence. This is really, I think, the nature of the disease is that it often takes time to truly declare itself. And also it can respond to treatments that we use commonly for eczema and psoriasis, which can sometimes muddy the picture. So what are the clues that help us? Mycosis fungoides or cutaneous T-cell lymphoma likes to live in what we call the bathing suit distribution. That means it's kind of in sun-protected sites. So like in this picture, it affects the buttocks, the thighs, often under the armpits or the breasts. In the groin as well. And unlike other skin conditions, it presents with patches and plaques. Patches are flat and plaques are raised of varying sizes and shapes. It tends to be persistent and progressive. And sometimes a helpful clue is something we call poikiloderma. And I'll show you some pictures of poikiloderma, but that just represents areas that are hyperpigmented, areas that are hypopigmented, atrophic areas where the epidermis is thinner, and telangiectasia, which is open blood vessels. And it's that combination that makes poikiloderma more visible. So these are some pictures of patients with patch stage mycosis fungoides. And it's in this picture on the left where you can see this is what is poikiloderma, where there's some areas that are like white, that's the hypopigmentation, some areas that are brown, that's the hyperpigmentation. The atrophy, you can appreciate that the skin kind of has like a tissue paper appearance to it, whereas the normal unaffected skin doesn't have that. And then the telangiectasia, you can see sort of in that redness. So this is what we would call a poikilodermatous patch. And again, it's in the very typical distribution of mycosis fungoides on the thigh. The picture in the middle and the other picture on the right show more kind of red to pink patches. And again, in the very similar distribution, this patient in the middle has a little bit more inflammation or more redness that you can appreciate. These are pictures I'm showing now of patients with plaque stage disease, and the difference between patch and plaque is that plaques are elevated. So you can see here pink to red raised plaques. A very kind of typical or characteristic feature of mycosis fungoides is also that it can be ring-shaped or horseshoe-shaped. I think that's why it sometimes is mistaken for ringworm or tinea corporis. The picture in the middle could very easily be diagnosed as psoriasis because they look very similar. And then this patient on the right in deeply pigmented skin has patches as well as plaques. And you can see there's a little bit of ulceration in some of those plaques. So I want to just show some more different morphological pictures. So where the rash looks the same, but also a little bit different. This patient has kind of two large erythematous patches on the abdomen with some papules, smaller raised bumps inside. This is again a much more typical presentation, kind of bright red patches on the buttocks and thighs. And then you can appreciate here, we've got a thick kind of infiltrative plaque on the right lateral eyebrow, where there's loss of the hair there on the brow as well, with some other plaques and patches on the face and neck. Here again, maybe we're getting kind of a flavor for what the presentation looks like. Brightly erythematous patches on the chest and abdomen with a more thicker infiltrative plaque on the arm. Um, in black and brown skin, it's sometimes more challenging to appreciate whether there is redness or inflammation. And also, more often seen in black and brown skin is a hypopigmented variant. Again, hypopigmented means that the skin is lighter or there's less pigment deposition. And you can appreciate in both these patients, there are hypopigmented patches on the thighs, the buttocks, and the arms. This subtype of mycosis fungoides actually has an excellent prognosis, and if it's in its classic form, responds to phototherapy beautifully. We'll talk about phototherapy too if there's time. This is another patient with richly pigmented skin who has some areas of hypopigmentation, but also hyperpigmented plaques and patches. Folliculotropic mycosis fungoides is another variant that has clinical significance. When you have infiltration of the lymphoma cells within the hair follicle, that's what folliculotropism means, meaning the malignant cells like to travel along and down the hair follicle. And when that happens clinically, you can sometimes appreciate that there's little bumps at the site of all of the follicles. So all of these little papules are follicular openings. And when they are filled with those malignant lymphoma cells, it causes kind of elevation at those sites. In some situations, when patients have that, it means that the disease behaves more aggressively and can sometimes be less responsive to typical therapies. These are other pictures of folliculotropic mycosis fungoides, where you can see here you've got more kind of, we would call these closed comedones or like skin-colored bumps. This picture on the left would require biopsy in order to diagnose. I'm not as astute to be able to look at that and say that you have mycosis fungoides. The other pictures are more characteristic. You can see there's a pustule here kind of along the active border, and that would be indicative that there's infiltration along the hair follicle. But this picture in the middle could very easily be diagnosed as ringworm or tinea corporis, and would not respond to topical antifungal therapy. And then you can have folliculotropic mycosis fungoides on the head and neck, and that presents with more kind of infiltrative or juicy plaques. Once we advance to tumor stage MF, you can appreciate that the plaques themselves become bigger and deeper, and are tumors. So the patient on the left has some, these are more kind of deeply seated tumors that aren't kind of popping out of the skin, but going deeper down. And the patient on the right, has very obvious kind of widespread tumors associated with patches and plaques in a deeply purple color. And then tumor stage disease, again, you can appreciate with this patient on the right, but also it can become ulcerative. And you can see on the foot here on the left, the tumors themselves are eroded and draining fluid. Very high risk of secondary infection in that situation. So how do we diagnose mycosis fungoides? And as I mentioned, it often is a combination of the clinical picture, the biopsy result, and then extra testing that we do. This is a scoring system that we use that I find sometimes helpful. It's really old. It was adapted from Elise Olson in 2005. And I think it speaks towards our growing understanding of the disease, that this is used, I think, infrequently, really in cases where you say, I'm not actually sure, is this an inflammatory skin condition like eczema, psoriasis, or mycosis fungoides? These pictures here on the left, again, are intended to show poikiloderma, which remember is where you've got hyperpigmented areas, brown, hypopigmented areas, white, atrophy, which is like that tissue paper, like wrinkling of the skin, and telangiectasia, which is the pinkness. So in terms of the points, and I don't think this matters, but really we look at whether a patient has persistent progressive patches or plaques on non-sun exposed sites with size and shape variation or poikiloderma. And then you look at the skin biopsies to say what's happening under the microscope. And is this the phenotype or the typical picture of those lymphoma cells that we would expect for cutaneous lymphoma? This is just a picture of what a biopsy looks like from some patient that we have who has a diagnosis of mycosis fungoides, although this was taken off the internet. And all of these little kind of blue cells that are collecting in nests in the top layers of the skin are the lymphoma cells. So how do we stage mycosis fungoides? And it's the typical sort of staging criteria that's done for all malignancies, which is the tumor, the nodes, the metastases, and in cutaneous lymphoma, we look at the blood as well. The T stage is very much just what's happening in the skin, and that's based on body surface area. So somebody who has T1 disease has less than 10% body surface area involvement of patches or plaques. If they're T2, it means there's more than 10%. T3 means somebody has a tumor. If somebody has a tumor and many patches and plaques, they automatically get upstaged to T3. So you go to the maximum stage based on the morphology. And T4 is based on whether or not the person has erythroderma, or what we call more than 80% involvement of body surface area. The end stage is whether the nodes are involved, the lymph nodes. Metastases is exceedingly rare in cutaneous lymphoma. And then the last stage is blood. And if patients have blood involvement, we classify it based on the number or the absolute number of lymphoma cells. And if somebody has more than 1,000 circulating lymphoma cells in the blood that we measure, then we would consider a diagnosis of Sézary syndrome. So body surface area calculations are really important because that's how we stage patients and offer their prognosis. And we use something called planimetry, which just uses the patient's hand with a full hand, including the fingers, accounting for 1% body surface area. And so if somebody just has a few patches or plaques that cover 1 or 2 of their hands, then they would have 1 to 2% body surface area. If somebody has much more extensive disease, then we use the percentages that we know. So the chest and abdomen in this picture are 13% body surface area. So let's say they have half of that involved, then they would have 7.5% there. In the clinic and in clinical trials, there is an assessment tool that's used to sort of categorize the severity of the disease, and that's called mSWAT. That stands for Modified Severity Weighted Assessment Tool. And basically, you calculate the percentage of body surface area of patches, plaques, and tumors. And for each of those, it's multiplied by a coefficient, with plaques being multiplied by a coefficient of 2 and tumors being multiplied by a coefficient of 4. So the more extensive body surface area that's involved, and whether it's plaque and tumor, the mSWAT goes up. We also have patients in our office complete what's called a Skindex 29, and this is a quality of life questionnaire that has 30 questions that patients answer, with questions being never, rarely, sometimes, often, all the time as their scoring system. And the questions surround based on symptoms, emotions of their skin disease, how it affects their function. All of these things are really important. And when you kind of decide on your agenda for a visit, I like to look at the questionnaire and say, okay, well, the things that the patient's dealing with often or all the time, we should address today, whether that's worried about the prognosis or severe itching, etc. Also, when we want to assess response to treatment, improvement in both the mSWAT and the Skindex 29 questionnaire are really important markers, objective markers of meaningful change. The other scale that we use is called the numeric rating scale of pruritus. And this is exactly what it looks like. You just rate the itch that you have, as 0 being no itch and 10 being the worst imaginable itch that you have. And again, when we initiate treatment, we want that number to go down. The prognosis of mycosis fungoides in patients who have stage 1A disease, which means just patches or plaques less than 10% body surface area, is comparable to the normal population, provided their disease remains as patch stage disease, with patch being better than plaque. And then you can see as the T stage goes up, the prognosis goes down. So patients who have erythroderma or tumors are going to have a worse prognosis. And then as we get into the overall stage, which is what's included in the graph here on the left, the A, patients who have blood involvement or metastases have a worse prognosis as well. The ProClippi study is done out of, this was actually an international registry of patients that were collected for a 10-year period. So it opened in 2015 and closed in 2025, and multiple cutaneous lymphoma experts across the world submitted these patients, and the patients were then prospectively, meaning from their moving forward in time, monitored in terms of their prognosis, the treatments, etc. I think over 50 centers had patients recorded with, I'm not exactly certain the full number, but 1,500 to 2,000 patients were submitted and monitored, which in a rare disease is a lot of patients. And really, when we look at the patients that were registered, if we have expected management in white, meaning just observation, in gray is skin-directed therapy, and then in black is systemic, the majority of patients' first-line therapy are being treated with skin-directed therapy. And what I find interesting and valuable in cutaneous lymphoma is that even as patients get more advanced disease or require systemic agents, skin-directed therapy continues. We sort of layer on treatments. We don't take away treatments as the disease progresses. So frontline management in somebody who has early stage mycosis fungoides, patches, or plaques is skin-directed, and we can use topical corticosteroids, which can help with itch and inflammation and redness. We can use topical retinoids, and that helps kind of normalize epidermal differentiation. Very commonly, we use topical nitrogen mustard, which there are 2 formulations that we have available in Calgary. And sometimes we use topical immune modulators called imiquimod. We also use a lot of phototherapy, where phototherapy is exposing the patient to ultraviolet B radiation, most typically, and that helps also with patch stage disease. So topical corticosteroids, I think, is what's used kind of most frequently frontline. Patients often, before they come to our clinic, have already been started on that treatment. And response rates, I would say, vary, with some patients doing very well initially, but not a lot of patients getting complete response, meaning this is not a cure to the condition, but it helps manage it. In our experience, I think patients very often and most typically under apply the amount of topical steroid for worry that they're going to cause thinning of the skin. And so I like to use this measure called the fingertip unit. And you can see right here, if you squirt the topical steroid on your hand from your distal, the end of your knuckle to the edge of your fingertip, that's what's called 1 fingertip unit. And 1 fingertip unit covers roughly about 2% body surface area. So if you remember that 1 full hand is 1% body surface area. So if you need to cover your whole hand on the front and back, that would be the equivalent of 1 fingertip unit. Let's say, for example, you have to cover the front of your chest and abdomen. That's about 14 hands, so you need 7 fingertip units. So that would mean that the patient has to squirt 7 times or on 7 fingers that amount in order to cover that body surface area. Most often when I explain the fingertip unit, patients realize, oh, I'm actually using way too little topical steroid. As I mentioned, topical nitrogen mustard. I like this more than topical steroid because I think it actually modifies the course of the disease as opposed to just sort of treating the symptoms. Carmustine we have, or Ledega mechlorothiamine gel. Ledega in Calgary is only available to patients who have very specific private insurance coverage, but we have access to Carmustine through the Alberta Cancer Centre. This initially can cause a lot of local irritation and inflammation, and it takes a long time for the maximum benefit. Up to even 2 years, I've seen patients continue to have improvement and sustained response. One thing that we notice and that I counsel patients on often is that sometimes because this system activates the treatment activates the immune system, you can have unmasking or appearance of other lesions where you haven't applied the topical nitrogen mustard that kind of light up. And that just means that it's working and that the immune system has been activated to say, oh, wow, we've got lymphoma cells on these spots and we're going to try to get rid of it. The limiting factors with this treatment is local irritation that can sometimes necessitate stopping the treatment. We've had patients too who get ulcers or erosions because they've applied it too robustly or too enthusiastically. And in that case, we have to take a break. As I mentioned, phototherapy, we use ultraviolet light to treat the skin disease. And that includes most often something called narrowband UVB phototherapy, which is a very specific wavelength of light that is only really directed at that 311 nanometers. And the risk of getting sort of other adverse effects at that dose are minimal. Sometimes we use psoralins that the patients can take as pills, which is a photosensitizing agent, and then UVA. That allows for deeper penetration into the skin and is better for plaque stage disease. And I'll talk about ECP later, which extracorporeal photopheresis is kind of like UV treatment for the blood. So these are examples of booths, phototherapy booths that patients would stand in, where the UV radiation is emitted from these long bulbs. And typically what you want for a patient is to stand in the booth. Ultimately, it starts off at 20 or 30 seconds only. And you expose the skin to the radiation, the ultraviolet radiation, for that tiny amount of time in order to just get kind of minimally perceptible inflammation of the skin 24 hours later. You build up your exposure over time, and somehow this treatment kind of modulates the immune system in order to target the lymphoma cells and get rid of them. Patients need to go to the office where phototherapy is offered 2 or 3 times a week initially, and then when remission occurs, you can cut back if possible. But this is really limited by where the patient lives, with anyone in a rural or remote area not having access to this, and the convenience of it with their work and their lives. It's not easy for anybody at any stage in their lives to travel 3 times a week for treatment. So that's my summary of cutaneous T-cell lymphoma, or mycosis fungoides, kind of skin-limited disease. I have updated this talk from when I gave it last to include this entity called primary cutaneous CD4 positive small or medium T-cell lymphoproliferative disorder. This is a mouthful, but we're getting a ton of referrals for this, and it's probably underreported in patient literature, although it's becoming very well known in the academic field of cutaneous lymphoma. So we can just call it CD4 positive small medium for short, but this presents as a solitary red bump or papule, often on the head and neck or upper extremities that may enlarge or persist for weeks. These 2 images are patients of mine on the right that have had a very typical presentation, 2 different patients, although it looks almost identical. Patients go to a doctor because they think initially it was a bug bite or a pimple, and then it doesn't go away and can get bigger over weeks. A dermatologist or a family physician usually does a biopsy, and the biopsy reveals the diagnosis. If the biopsy report is consistent with this diagnosis and pathologists are getting better at recognizing this entity, and you're confident that it was one lesion, really there's no staging that's required, or imaging or blood work. This is something that just typically goes away with biopsy, even if the margins are positive, meaning they just sampled a part of the lesion as opposed to removing the whole thing. It often involutes on its own with biopsy. This is not somebody who has a life-altering or life-threatening diagnosis of cutaneous lymphoma. This is a one-time odd diagnosis that goes away typically with biopsy and doesn't require further aggressive investigations or treatments. So I bring this up to your attention here in case you're somebody who has this diagnosis. And if the diagnosis has been confirmed and reviewed by someone who knows about this, then it's really not something to worry about long term. And now we'll kind of jump from the most benign end of the spectrum of cutaneous lymphomas to a more aggressive variant, and that's Sézary syndrome, where we have patients who have blood involvement. So the lymphoma cells are circulating in the blood and kind of depositing in the skin, which is what causes the erythroderma or redness. So these are patients of mine who have Sézary syndrome, and you can appreciate a very distinct difference between the patients that we saw who have patches and plaques and tumors. This patient had very widespread red skin with thickened areas and a very kind of plate-like scale. And again, you can see sort of involvement of the entire lower legs, but also like redness in the inguinal folds and laxity of skin from weight loss. Here's another patient of mine who has what we call erythroderma, so redness and scaling of the body more than 80%. Patients with Sézary syndrome also get what we call a keratoderma, and that means thickening of the skin on the palms and soles. Here's a picture of the keratoderma on the soles of the feet, so very thickened, scaly skin on the feet. So those are some pictures of what Sézary syndrome looks like. And now with our remaining, yeah, we've got still lots of time, 15 minutes. I'll go through some of the more advanced therapies for, systemic therapies for advanced cutaneous lymphoma and Sézary syndrome, with the goals of treatment really to ideally control disease progression, to manage and treat the symptoms, which is often debilitating pruritus or itch, improve the appearance of the skin, enhance the quality of life of the patient, and ideally minimize the effects of treatment. So all of these things are taken together with the important result of trying to prevent progression of disease and improve patients' quality of life. So general principles in someone with advanced cutaneous T-cell lymphoma that, like I say, you don't abandon skin-directed therapy. You use skin-directed therapy in addition to systemic therapy. It often can take a long time to see a full response, and treatments can move slowly. So you can't decide after a month or even 2 months whether or not to abandon the treatment. We usually try to select treatment that will be more tolerable first, although that's evaluated on a case-by-case basis. And unlike other lymphomas or leukemias, we can reuse therapies that maybe worked in the past and stopped working, try something else that maybe helps, and then revisit a therapy previously. And then, ideally, somebody who has very advanced disease would be enrolled in a clinical trial. And these are expanding in Canada, although, the major clinical trials occur in the United States and worldwide. So which patients require systemic therapy? This is tricky and again is really individualized. But somebody who has tumor stage mycosis fungoides, advanced mycosis fungoides with lymph node involvement or organ involvement, which is exceedingly rare. Sézary syndrome for sure requires systemic therapy. And those who have early stage mycosis fungoides, who have certain high risk variants like follicular tropic, which we talked about, who have very extensive body surface area, who maybe have a small percentage of circulating lymphoma cells in the blood. So really systemic therapy can be required at any stage of the disease. So let's talk about some of the treatments that we use. Interferon is a mainstay of treatment in cutaneous lymphoma. It's the workhorse I find in somebody who has extensive plaque stage disease or tumor stage disease. We've struggled a lot with interferon. Even since I've been practicing, we're now into its third iteration. But in December of 2024 and January 2025, there basically was an entire worldwide shortage of the previous formulation called Pegasus, meaning all of our patients, we had to ration it. We had to decide based on a scarcity model who would continue to get treatment and who wouldn't. It was really quite terrible. But luckily, Health Canada approved kind of more expeditedly something called Ropeg interferon or Besrami, which we now have access to. Besrami is given as an injection once every 2 weeks. And interferon works by restoring the balance of the immune cells in the skin. Interferon is a normal molecule of our innate immune system that helps us fight infection and modulates our immune system. When you get the flu, for example, and you have fevers and chills, it is your body's own circulating interferon that kind of gives you those symptoms. So understandably, when you give it to yourself, you can get flu-like symptoms. It does require blood work monitoring of the thyroid and the liver, specifically, and the blood counts. But we have patients who do exceedingly well on this treatment and whose tumors and plaques improve dramatically. Oral retinoids are vitamin A derivatives, and these work particularly well in patients who have follicular tropic variants of mycosis fungoides or in Sézary syndrome in combination with other treatment modalities. These alter the lymphoma cell growth and cause them to die more quickly. The main treatment that we use at our center is called alitretinoin, or Hanzima is another name for it. And again, just like interferon, it requires monitoring, with the main side effect being dryness of the skin, like dry lips, dry eyes, dry mouth. In the certain patient populations, patients with a uterus or of childbearing age, it is highly teratogenic, so you have to monitor about contraception. And then I talked about ECP before, and we're coming back to it now. Extracorporeal photopheresis is a key treatment for Sézary syndrome, and we're very lucky in Calgary to have access to it here. Basically, what happens is through a peripheral IV, a patient with Sézary syndrome's blood is removed, extracted, and then they spin out or take out the white blood cells. Remember, Sézary syndrome is a problem of the white blood cells, those lymphoma cells. And then they treat the white blood cells with something called psoralen, or here it's called 8-methoxypsoralen. That's the like photosensitizing agent. And then they give those treated white blood cells UVA radiation and expose it to UVA. And then they put them back, those blood cells then go back into the patient's circulating blood system. So each treatment actually only treats about 5% of the circulating blood cells, of which maybe a smaller portion are the malignant lymphoma cells. But it has a remarkable impact on the body's immune system, its ability to modulate and affect the other circulating lymphoma cells. And this, in combination with a retinoid and interferon, is kind of our frontline therapy for somebody with Sézary syndrome. Patients on extracorporeal photopheresis notice relatively quickly improvement in their itch and rash, which is quite remarkable. The frequency of treatment, because you have to go and they use an IV peripherally, it takes a couple hours per treatment, is variable. The textbooks will say that patients have to go for 2 consecutive days every month. But we have very, very many different regimens. Some patients who need like an immediate kind of offloading or decrease of the blood burden can go weekly. Some patients go once every 2 weeks, etc. And then in patients who have widespread patch, plaque, or tumor stage disease without blood involvement, or those with blood involvement who are maybe preparing to go for an allogeneic stem cell transplant, total skin electron beam therapy is an option. And this is a highly specialized form of radiation that only targets the layers of the skin. So it's not penetrating deeply, it's just treating the skin, but it treats the whole body surface area. And this works remarkably well with improvement in skin-related symptoms and induction of remission in the skin compartment. Unfortunately, unlike photopheresis, which we have access to in Calgary, total skin electron beam therapy is only available in 3 centers in the country. So it's available in Winnipeg under the care of Dr. Cook. It's available in Hamilton, and it's available in Montreal. We send probably 6 or so patients to Winnipeg or Hamilton per year for consideration of this therapy. And I've just included here some sort of patient testimonies about the experience. The treatment I had in Winnipeg has made a radical difference in how I feel. The itch is almost gone now, and that is amazing. I saw my dermatologist today and he was rejoicing with us. Further treatment, travel, and accommodation expenses at this out-of-province facility would be cost prohibitive for me and my family. So having to travel, the treatment itself is covered if you go to Winnipeg, somebody from Alberta, but everything else is paid for out of pocket, and you have to stay there for several weeks. Our whole family would be thrilled if there could be a total skin electron beam program here in Calgary, and I would be too. And then I mentioned before radiation treatment. So radiation, if it can't be given to the whole skin surface, is used beautifully to treat tumors as they come. And this can be for palliative symptoms, but also to, I think, modify the course of the disease. It's often used in combination with systemic and skin-directed therapy. And then the last two agents that I'm going to talk about are newer treatments that we have. Brentuximab vedotin is a drug that is used in tumor stage disease, most often mycosis fungoides. And the tumor cells, the lymphoma cells, most often or can often carry a cell surface marker that's called CD30. And brentuximab vedotin is a targeted chemotherapy that uses an antibody to bind to that cell surface marker called CD30, which gives it access to the lymphoma cells. It is a treatment that's given every 3 weeks through an IV, and we have access to it in Alberta for patients for up to a year. With lots of patients, more than half of patients responding, and response rates lasting several months. And then lastly, we'll talk about a treatment called mogamulizumab. Again, we're talking about these targeted antibodies. And this target is something called CCR4, which is a chemokine that's involved. Chemokines are parts of our immune system that tell the immune cells where to go. And so CCR4 is a marker that lives on lymphoma cells that tells them to travel from the blood to the skin and vice versa. This is used most often in patients who have blood involvement. In the Maverick trial or the clinical trial that looked at this, the best response was seen in patients who have blood involvement. It is also given intravenous every 2 weeks. And this can be continued as long as patients respond. Interestingly, the most common side effect that we see with mogamulizumab is a rash, and that occurs in about 50% of the patients. This can be very challenging, as you can imagine, to try to differentiate. Do you have a rash because of your treatment or because your cutaneous lymphoma is active? So again, it requires multidisciplinary care to discern the etiology of the rash in somebody who's being treated with mogamulizumab. So in summary, I feel like I blew through that quickly. Mycosis fungoides and Sézary syndrome are rare diseases. Diagnosis is challenging and requires review of the clinical picture, the skin biopsies, and all the other investigations together. Management is skin-directed for early-stage disease and is often layered on to systemic therapy in patients who have advanced disease. And really, the rarity and complexity of this diagnosis is best served at a center where there is multidisciplinary care and patients and physicians who are experts in this condition. So thank you all for listening, for your time. And I want to just let you know that there is a chance to have question and answer in the cutaneous lymphoma Q&A.
Thank you, Dr. Harden, for that very informative information. And like it was just mentioned, for the audience to have your questions addressed, please be sure to attend the cutaneous T-cell lymphomas or CTCL Q&A session that will begin in a few minutes. Thank you and see you soon.
Thank you.